Welcome to my new series, Clinical Case Scenario. In this series, I will attempt to discuss each day one clinical case. And these are real cases, and I will discuss how to go about coming to a diagnosis and management. And at the end of the discussion, I shall also give you some questions and also some tips or information on the subject concerned. Okay, let's start with our first case scenario 1. The history of the patient. Okay, here the patient is a 41-year-old female who presented with right hypochondrial pain for 1 week. It was a dull pain, initially mild but increased over the next few days before admission. This was accompanied by yellowness of the eyes, dark urine, and generalized itchiness over the whole body. She had low-grade fever, but no urinary and bowel symptoms. She also complained of mild, vague epigastric pain for the past 3 weeks before her admission. She has been feeling unwell with loss of appetite and nausea, but no vomiting. She had been on oral contraceptives for 2 years. She had an ovarian cystectomy 2 years ago and no other surgeries before. She is not a diabetic or hypertensive. On examination, she had a temperature of 38 degrees Celsius and was deeply jaundiced and no pallor. The heart rate was 96 per minute and the blood pressure 100/20 by 72 millimeters of mercury. The abdomen was mildly tender in the right hypochondrium and epigastric regions. No guarding, and the rest of the abdomen was soft and non-tender. The liver and gallbladder were not palpable and no masses were palpable. Okay, now these are the questions which I pose to you. Please go through the history and the physical examination and answer these questions 1 to 5 before looking at the answers that I'm about to give you in the discussion later. Now we come to the analysis of the case. Okay, this is a same thing that I showed you just now, but here I've highlighted the important points in the history and the physical examination in blue. Okay, so the important things in the history, the patient is a female, 41 years old. The 1 week history of right hypochondrial pain. The pain, dull ache in nature, initially mild but increased over the period days before the admission. This was accompanied by yellowness of the skin, eyes, dark urine, and generalized itchiness. She had also fever, okay, but no urinary and bowel symptoms. She had epigastric pain for the past 3 weeks and has not been feeling well since then. She's been on oral contraceptive for the past 2 years and had an ovarian cystectomy 2 years ago. Okay. And in the examination, she had 38 degrees Celsius, deeply jaundiced, and tachycardic with a 96 beats per minute, but she did not have any hypotension. There is tenderness mildly in the right hypochondrium and epigastric region. There's no guarding, or the rest of the abdomen was soft, liver, spleen, not, and gallbladder not palpable. Okay, so from the history, you have come to this. These are the features that you have got: yellowness of the eyes, dark urine, and itchiness. Epigastric pain for 3 weeks, feeling unwell with loss of appetite, and on is known to have been on contraceptive. And these are the relevant negative symptoms. No urinary or bowel symptoms, no medical illness. What I want to know further is whether chills and rigors is associated with the fever. Okay, there's no mention of this, which we want to know from the patient. And also there's no vomiting of any sort. Okay, so this is also not mentioned in the end. In fact, there is no vomiting. Okay. So from the history, we come to with this history, with all these features which I've mentioned just now, of obstructive jaundice with right hypochondrial pain in a female patient aged 41. Okay, these are the likely causes. Acute cholecystitis, CBD stone and cholecystitis, acute pancreatitis, cholestatic jaundice due to the contraceptive, hepatitis, bile duct strictures, periampullary carcinoma, and carcinoma head of the pancreas. These last two are highly unlikely due to the acute onset of 3 weeks and the patient being young. Now, in the examination, the issues that we mentioned were fever, deeply jaundice, and mild tenderness right hypochondrium. Okay, and the relative negative findings in this patient, she did not have any pallor, and there was no guarding. Okay, this will suggest unlikely to be an acute inflammatory condition. The liver, spleen, and especially the gallbladder was not palpable. Okay, and there were no other masses, especially in the epigastric region. So with this the findings, the possible diagnosis, what are they? Okay, now we have got more information. 41-year-old female patient with 1 week history of jaundice and fever, and now she has confirmed to be having fever and mild tenderness in the right hypochondrium. Likely causes will be common bile duct stone, choledocholithiasis, with obstructive jaundice, ascending cholangitis, bile duct stricture, and acute pancreatitis. Okay, these are the 4 likely causes that we can entertain after analyzing the history and the physical findings. So after we have come to a clinical diagnosis or clinical problem. What is the clinical problem of this patient? Is the patient with obstructive jaundice and ascending cholangitis. Okay, that is the problem. Now we have to find out what causes this problem. That is, what's the diagnosis of these problems. The provisional diagnosis, as we have already entertained, is a choledocholithiasis with obstructive jaundice and complicated with ascending cholangitis. So differential diagnosis will be bile duct strictures, carcinoma head of pancreas, cholangiocarcinoma, and periampullary carcinoma. These 3 are unlikely to be the cause because of the patient is a young patient and the history is very short. So your question number 1, what are your differential diagnoses? Okay, these are the differential diagnoses of we have mentioned. Of course, we also add in cholestatic jaundice due to the oral contraceptive. Okay, so name the investigations for the patient. So the patients, we do a routine investigation as baseline, and in particular we do a full blood picture looking especially for leukocytosis. Renal function, look for evidence of renal failure because of hepatorenal syndrome. Urine analysis and serum amylase, just in case it is acute pancreatitis. Liver function test is a very essential investigation for this patient. And we look into the bilirubin, especially the conjugated and unconjugated bilirubin levels, which will give us an idea of the nature of jaundice. Serum alkaline phosphatase also will be markedly raised in patients with obstructive jaundice. Then the liver enzyme AST and ALT is also important, which may indicate whether there's some form of hepatitis is the cause of the problem. And of course, albumin is important to know the liver function. So patient with jaundice, coagulation profile is very important. So we must do a prothrombin time, clotting and bleeding time as well. In the imaging investigations, the most and the preliminary investigation will be an ultrasound scan, which will give you the nature of the gallbladder, presence of gallstones, the dilatation of the bile ducts, especially the common bile duct and intrabiliary ducts, and at the same time, in a small percentage of patients, the possibility of stone can also be detected in the common bile duct on ultrasound. Ultrasound will also help you to look at the liver to see if there are any other foci of infection or tumors or cirrhosis. And the other one is whether the pancreatic head is bulky or there's a mass lesion there, to look at that. So ultrasound scan, although not the best, will help to determine all these conditions. As the patient is jaundice, and depending on ultrasound, if the ultrasound does not show any mass lesions, then we straight away go for an ERCP for this patient. And ERCP will determine the cause of the biliary obstruction, whether it's a stone or a tumor. And whether the CT scan is necessary will depend on ERCP. Because if it is a stone, then ERCP sphincterectomy can be done to remove the stone. So the final diagnosis from this patient from history, physical examination and investigation is cholangitis with obstructive jaundice and ascending cholangitis. With this diagnosis, then we have to entertain or go into the subsequent management of this patient. Management of this patient, starts with resuscitation. IV fluids and electrolyte balance must be ensured. Antibiotics, broad spectrum antibiotics with metronidazole must be instituted for the patient. Correction of coagulation disturbances are important with the injection vitamin K regime. And when these three conditions are met and the patient is more stabilized, then you have to think of a definitive treatment to either how to remove the stone. The best and the easiest method these days will be a ERCP with sphincterectomy and extraction of the stone. And at times you may want to put a biliary stent. Laparoscopic cholecystectomy may also be done at the same time if the patient is stable. Otherwise, it has to be postponed to a slightly later date. If for some reason ERCP is not available, you may have to explore, open exploration of the CBD and removal of the stones plus placement of D-tube. Okay, this is very important because you cannot wait too long for the patient because patient may go into septicemia. Okay, next question 5. What is Charcot's triad and what is the Covace's law? Okay, Charcot's triad is a triad consisting of jaundice, pain, hypochondrium, and fever. And this fever is classically associated with chills and dry coughs. These three together is known as Charcot's triad, which is a diagnostic feature of cholangitis. Okay, patients with cholangitis may have all these symptoms or may have at least one of these symptoms. And I must emphasize here, these three symptoms are usually intermittent in nature. They come and go, okay, until they can develop sepsis. Covaceous law states that in the presence of jaundice, an enlarged gallbladder is unlikely to be due to gallstones. This may be explained by the observation that gallbladder with stone is usually chronically fibrous and incapable of enlargement. Okay, so in this patient, the gallbladder is not palpable. Therefore, it is unlikely due to a tumor. It is more likely due to be gallstone obstruction.